and welcome everyone to the post-film panel discussion. And Ashley, if you could launch the poll that we're going to be taking for everyone here. And as you have a chance to answer the poll, I'd like to just start by asking our panelists, and actually I'm going to start with Dr. Nicole Rochester in thinking about this particular film. What resonated with you, Dr. Nicole Rochester? If you could lead us off.
Sure. Well, first, I just want to thank you, Robin, and thanks to Health Advocate X for having us. It was a very powerful film. I'm looking forward to the discussion. So many things resonated with me. This is now my second time watching, and I was still jotting down thoughts and notes and things. But I think one of the scenes that really struck me and actually brought me to tears the first time I screened the film was when the young lady, I think her name was Daisha, talked about the incident where they had a field day at her school and everyone was, swimming and they had on their bathing suits. And because she was ashamed of the color of her skin, she hid in the bathroom all day. And I think, being a mom, being a woman of color, being a pediatrician, and hearing that beautiful child tell that story of not just the shame that she felt, but the fact that she was invisible to not, her classmates, her teachers, the school. No one came to look for her, for the entire school day. She was missing. And so that just really struck me. And it just, made me think about how, in many ways, people of color are invisible in the healthcare system as well. And I'm sure we're going to unpack that a little bit more later.
For sure. Yeah, because obviously this film was not focused on the healthcare system. And so we're going to be talking a lot about that in a moment. So Dr. Nwando Anyaoku, it's great to have you here as well. And what were your reflections? What did this bring up for you?
Let me add my thanks for this filming, because this conversation is so important. For me, I grew up in West Africa. And so what struck me was the early scene in the movie when the children were talking about when they first realized that they were Black, and I remember when I had that thought to myself, and that was when I came to the US after medical school and I was in graduate school, and sort of moving through life, and suddenly realized one day that in this country, I'm considered Black first. And that actually paused me in my steps, because that was not my reality growing up. The colorism issue, which was also discussed in the movie, is something that, was real to me. But that recognition that people see your race first and people filter everything that I am and do through that lens was a bit jarring. And I actually, when I watched it, I heard them saying that, and it took me right back to that moment. As an adult, how jarring that was for me, and just thinking of what those children had the words to actually say, which was actually the other thing that was really striking about the movie, how these children have language around these experiences.
Yeah, truly amazing. Annie?
Thank you, Robin, and thank you, Dr. Rochester and Dr. Anyaoku. I'm calling in today from the unceded territory of the Lasan Ohlone in the Oakland Hills of California. And watching this film for the second time, I'm appreciating even more. And I feel so inspired by these kids and young adults. And I accept their invitation. Their invitation is, we need to talk about this. And they've modeled that so beautifully by introducing us to the language. You can't talk about something if you don't have the language to be able to talk about it. And I'm eager to take some of the ideas they brought up, the language of racism, stress, discrimination, microaggression, and talk about what that looks like in healthcare and what we as healthcare advocates can do. So thank you.
That's great. So thank you for those opening reflections. And I'm just going ahead and sharing our poll. Do you believe that bias contributes to healthcare disparities? And maybe not so surprising. 100% of the people that are viewing the film today do believe that that is true. So in thinking about, your personal experiences in the medical system, can you each share a story about how bias has dramatically impacted patient care? And maybe Dr. Anyaoku, if you would like to lead the panel in responding to that question.
That's such a big question because for patients, who are underrepresented minorities, whether, for the purpose of this conversation, focusing on race, there are so many ways that it shows up. The big example that's been in the news lately is about the pregnancy and birth outcomes, and how outcomes for women of color, Black women, are significantly different from their white counterparts. They're 4 to 6 times, actually even including Native American, Indigenous women, that their experiences, they have pregnancy and birth outcomes 4 to 5 times, sometimes 6 times worse than their Caucasian counterparts. And so for birthing people going into that space who identify as people of color, that adds a significant level of stress. And why does the bias show up that way? Research shows that often their pain is not believed, and pain is, we recognize it as a warning sign. And so when you have a birthing person telling you that she's in pain or they're in pain, and you don't believe them, you allow the opportunity for bad outcomes to happen. And if they don't have access to healthcare and all the different layers that disparities and bias show up in the way that we care for people. But, just speaking from the medical perspective, that bias that says that this person is drug seeking, or whatever story you've heard or you've formed in your head based on stereotypes, it can actually lead to really significantly dangerous consequences for people of color.
Thank you for that reflection. And we had hosted a community conversation, I think it was last month, for actually maybe in January, talking about not only bias, but maybe, standardization of treatment based on bias that has already been in the healthcare system for so long that many of us don't even understand. It's just standard protocol. And I was really shocked to hear that. Dr. Rochester, would you like to kind of take us through how that has happened and how that affects patient care today?
Yeah, thanks, Robin. Yeah, I mean, there's so many ways that bias and racism are baked into the healthcare system. If we go back to the very beginnings of the healthcare system in the United States and the role that physicians played in really upholding the institution of slavery, literally doing examinations to determine the worth of enslaved people based on their physical characteristics, their perceived strengths. Many of the erroneous theories and stereotypes and beliefs that are persistent in medicine today, things like Black people have thicker skin, to Dr. Anyaoku's point, Black people don't feel pain the same way. Those beliefs originated from white American physicians back in the early 1800s, 1900s. And there were papers that were written, and there were presentations done at conferences like the American Medical Association, and people that were, there were statues built in honor of physicians such as J. Marion Sims, who performed surgery without consent on enslaved Black women. So there is a dark history in healthcare. And one personal experience I can share is that my late father had diabetes and other chronic conditions, and had some complications, including end-stage renal disease, and ultimately became a dialysis patient. And many of you may be familiar with kind of the recent uncovering of the race-based algorithm that has been part of medicine, for centuries, decades, centuries, where we were, quote unquote, correcting for race. And ultimately the outcome of that was that Black patients with kidney disease were deemed eligible for transplantation much later, at a much more advanced stage than their white counterparts. And, I'm certain that my father was subject to that algorithm, and that it ultimately impacted his care, and the fact that he and many other patients of color are not even offered transplantation as an option. So, we have a lot of work to do. And I think it starts with education and awareness. So I'm glad that, like, to Annie's point, I'm glad that we're talking about this today.
And Annie, being a former health advocate and working on these issues, do you have any reflections on maybe how you've seen bias in patient care as you've worked in that role?
Yeah, I do. I'll give you an example, sort of a day in the life of example. So I had a client who was post-stroke with severe central nerve pain, which presented as an intense burning. And post-stroke standard of care calls for statin therapy, but she didn't tolerate the statins because she was, one of a certain percentage of people that have intense muscle pain. So what she was choosing to do was manage her diet and get frequent lab work. So we went in to see a new physician. She had just moved to a new assisted living community in a new county. And the physician said to her, my client, very eager to mitigate stroke risk, said, I'd like to request a lipid panel. It was a little early. And the physician said, why? You're not going to do anything about it anyway. And this is, immediately that remark registered as a stereotype. And there was a great missed opportunity there, and a lot of harm caused, right? There was stress, there was alienation, there was delayed care because my client wanted to understandably find a new physician. And so I helped her find a new physician who, she was Afro-Brazilian, my client. And so we found not a Brazilian, but somebody from Latin America who very patiently built trust and was able to introduce a statin that in fact didn't cause the muscle pain. And so this could have had life consequences, right?
Thank you for sharing that example. And I want to encourage the audience also. This is not just a panel discussion, amongst us here. We'd like to also answer your questions. So please use the Q&A feature if you can for answering or asking your questions, and we'll go ahead and I'll offer them to the panelists as they come in. So thinking about the film, do you think that we've made any progress on race and racism, bias, stereotypes in the healthcare system? What do you think about that?
I think the beautiful thing about the film is that we are actually beginning to have the conversation, and that we're beginning to have the conversation at every level of society, from the youngest children to older people, that we're sharing in forums like this, that there is impact, that there is a difference in the way people experience care, that there's data that's beginning to show that, right? We've known that for a long time, but I think now, as a consequence of the time of our society and the events of the last couple of years, it's actually much more prevalent in public conversation and public discourse. And so, is it progress? You can't make progress until you can discuss it, until you can lay it on the table and identify it. And then we can start to think about how we can move the needle in the right direction. And so I'm really encouraged that the conversation has begun. And I have great hope that we'll move forward now that we are all able to talk about it. Not that talking about it is easy, because sometimes you have a couple of conversations and then folks are like, I can't deal with this anymore. Isn't this over yet? And I've heard that. No, it's not over yet. We have a long way to go, but we have started.
That's great. Dr. Rochester.
Yeah, I mostly agree with Dr. Anyaoku. I mean, I think I have these periods, honestly, because in addition to being a health advocate and a physician, I'm also a health equity consultant. And so I am, and I know you know this too, Dr. Anyaoku, you see it in your work every day. I have these periods where I'm really optimistic and I'm hopeful. And then something happens, or I go on Twitter, why do I dare do that? And then I see some type of discourse that involves a healthcare professional saying something completely inappropriate, someone who's, either taking care of patients or supervising people in training, and then it knocks me down. And so I would say, every week, this is my life. Like, so today, in this moment, I am feeling hopeful. And I agree that, it definitely starts with these conversations, and there are lots more of these conversations happening than even 5 years ago, let alone 10, 20, 30 years ago. So I have to believe that there is going to be continued progress. I do still have reservations about the fact that there are systems that are much bigger than us. And so, both are necessary. We need to begin to change hearts and minds, and we need to educate, and we need to raise awareness. And we have these systems that are in place that have these entrenched oppressive policies that all need to be dismantled. And that's a daunting task. And I think that right now, what's largely happening is the placement of Band-Aids, and really, we need complete surgery. Like, the healthcare system needs to be dismantled, put back together. So that's what gives me a little bit of pause, but mostly I am hopeful.
Thank you for that. And Annie, do you want to chime in here also? How you're feeling, if you feel like we've made progress?
Well, I see conversations taking place, pockets of conversation, some more genuine than others. I see some interesting initiatives taking place, and I think the jury's out on some of them. But I guess in terms of, what the actual on the ground experience is, I would have to turn to my BIPOC brothers and sisters and ask them what their experience has been.
So I think in talking about healthcare systems, and there's a question in the Q&A about what role do ethics committees play in the medical system. And I know that a lot of healthcare systems also have patient and family committees in addition to ethics committees. So how are our healthcare systems adjusting to the interest and focus of these issues? And maybe Dr. Anyaoku, since that's kind of what you're doing at your system right now, you can lead us in this discussion to give us a bird's eye view.
Yeah, I think that often people think, well, this should be easy, right? Healthcare systems and healthcare delivering folks understand this. This is what they do. But the first thing that you have to recognize is that people have to see themselves in a positive light. They just do. And so telling people who have gone into a profession to help that they may actually be causing harm requires you getting past the shield, because that's the first thing you'll get. Are you kidding me? I treat everybody the same. How can you tell me that I'm treating somebody differently? So being able to provide data, qualitative and quantitative data that shows that the experience, the access, and the outcomes for different populations, for BIPOC people, for it's just different. And it's not because you did it. To Dr. Rochester's point, there are systems that are beyond you and I. I love the comment in the movie that talks about the 4 eyes of oppression. And one of those is internalized racism. So sometimes in health systems, they'll be looking at someone who's reporting being treated badly because of their race. And then they'll analyze it and say, well, the physician was Black, so it couldn't have been racist. Well, yes, it could, because the system says that it is okay to treat these people less than, right? And after a while, we also internalize it. So having that conversation can be really challenging. So as a system, how do we start to surface the data, put a filter of race, ethnicity, and language on all the data we collect gobs of data all day long, and we sit and admire it and nod at it a lot of time. But how do we put that health equity filter on it? to see how it shows up in different populations. Because if you're in a place where I live in Seattle, where the African-American population is 6%, well, if you're doing great for the rest of and the indigenous population is less than 2, you can be doing phenomenally well for the other 90% of people. But for these small fraction of people, you're doing a horrendous job, but it's not going to show unless you disaggregate the data. So that's the first thing to do, is to actually show it so that you can recognize it. And then listen to the voice of the people telling you how they are experiencing your care. Do you have a process by which you honor and amplify their voices? Can you actually say that you know what they're reporting to you? You know, don't dismiss all of them as, oh, well, nobody died, so clearly nothing was wrong. I'm like, that's like not even a low bar, it's on the floor, because the goal is not for people to die. And so
Right.
telling me that because nobody died, nothing went wrong, it doesn't say that you've done anything good at all. So really being intentional about honoring and amplifying the voices of the communities who are telling you how they're experiencing your care, who are telling you how they experience your physical plant and all the things that we do, so that we can actually begin to, you know, pay attention to that, because those systems
Oh,
to build. And so peeling back that onion is going to take sustained and consistent effort. Am I frozen or are you?
I think you were frozen, but now you're unfrozen. And I'm really
Go
curious.
ahead.
Oh,
It says my internet.
is unstable.
Go ahead, I'm good.
Okay. I think that's a really interesting question that I'm really curious about, is that health equity filter, or you know, in different disease states, there's feedback on like a quality of life score or something like that, that's standardized, right? So we can get a gauge on how people's care and life vary over time. Are there standards around health equity, you know, how people are treated and their care? Are there those filters built yet, or is that something that the healthcare system is doing?
So we do have those filters, and you know, so healthcare systems assess patient experience. We have Press-Ganey scores, right? And if you just look at that data writ large, it just says that of all these patients, these ones were happy. But if you look at that data and then apply the filter of race, ethnicity, and language, right? So break it out by who is answering the questions, right?
Mhm.
Then you can look at the answers by each subset. And so those filters are now being integrated into established data sets, just to start with where we are. And then there are other ones that are growing every day.
Interesting.
Hey, Robin,
Yeah.
I'm
go
sorry
ahead.
to interrupt,
Yeah.
but can I go back to that question about the ethics committee really quickly?
Yes.
I
Absolutely.
think that's a fascinating question, because it acknowledges that I mean, this may seem like a no-brainer for us, but it acknowledges that it is unethical, right, to treat people in healthcare or in any system differently based on their race. So I just love the idea of this falling under the purview of an ethics committee. To my knowledge, and I would love to hear from Dr. Anyaoku, I'm not aware of this being like standard, but it also brings up the fact that more and more hospitals are seeing racial health inequities as a patient safety issue, as a quality issue. And so, you know, we can't like relegate this over to like the DEI committee. You know, those people need to be involved too, right? But a lot of times this work is minimized to, well, this is DEI work. This is the work of everyone, of the entire healthcare system. And it is a patient safety issue. It is a quality issue. It is an ethics issue. And I think that that is kind of the future of really addressing health inequities in all of those different buckets, so that it's really viewed as this is an issue for everyone, and not like, oh, this special designee off to the side.
Well, and as health advocates in our community, do we have the opportunity to even bring that up or be in contact with hospital systems to help them see it that way? Like, is there a role for the health advocacy community in that?
I think that it's wonderful that in the last year, the different healthcare advocacy organizations came together and added a diversity, equity, and inclusion and justice component to our code of ethics. And I think it, just by virtue of doing that, also, sort of elevates our role or speaks to our role in speaking up about bias and interrupting bias when and where we see it, as we're providing healthcare advocacy services. And I think healthcare advocates are in a great position to those in health organizations to be involved, to ask for a seat at the table in hospital committees related to ethics and patient care and safety, to elevate DEIJ and amplify voices.
Mm-hmm. I
just wanted to add that the ethics committee is a very critical partner in this journey, right? Because to Dr. Rochester's point, this doesn't work if it's one person's job. It needs to be integrated in the way we look at how we're delivering safe, high quality, equitable care to everyone. And so all the different players whose job it is to be an advocate for high quality, high reliable, quality, safe care that's also equitable. Everybody has to have a say in that. And so you can have the ethics committee be the one who waves the flag, because sometimes the quality committee looks at it and they can't really see it, and the ethics committee can come to the table and help to look at it, through a deeper lens. So we all have to be partners in this journey.
Annie, did you want to jump in here? Okay. So Tammy Garcia says that understanding that patients want providers who look like them is very important, but unfortunately here in Colorado, there is not one Black primary care provider in our Denver metro area spanning 100 miles out. How do we change this? And she says, we are a teaching hospital. I've personally contacted the medical school asking why we don't have Black representation, and their reply is they receive very few applications from people of color. This seems unacceptable. How do we as a community change this? Thanks, Tammy, for asking this question.
Wow, I'm still stuck on there are zero. I mean, I'm used to maybe a few or a handful, but zero. I think my main response to that, first of all, Tammy, thank you for advocating. Thank you for asking the question. And Robin, I agree with you. It's not acceptable to just say like, oh, we don't get enough applications. That's the same excuse that we hear in other, corporate America for why there aren't more people of color as in VP positions and CEOs and all those things. So, it requires intention. It requires action. It requires planning. And also I want to say that, not no one, but most don't want to be the first or the only. For those of you who are on Twitter, this match day was, I think, last week, when that's where medical students find out where they're going to match for residency training. It's a whole thing. And there've been so many beautiful posts from people of color, students of color, about their excitement about matching at their top institutions. And then there've been a few posts where someone has said, I'm going to be the first Black, even in 2023, like I'm going to be the first Black neurosurgery resident or the first Black ex-resident at this institution. And not surprisingly, among the congratulatory wishes are other physicians of color saying like, I'm praying for you, like, call me if you need me, because that is that can be a very challenging experience. And so going back to Denver, if they don't have any within a 100-mile radius, it's also not surprising that maybe they aren't getting that many applications from students of color. And even if they get some, if you go visit the campus and you see no one, not only in the medical school, but in the grocery store, at the gas station, like no one in sight that looks like you, that's going to take a lot of reserve to be comfortable putting yourself in that position, knowing what we just, saw in the film and knowing what about bias and discrimination. So I think that institutions, all institutions, but particularly those that don't have adequate representation, really need to do the hard work of not only attracting diverse candidates, but also making them feel that they're welcome, making sure that, you know, they feel included, that they belong, so that they can keep and retain that diverse talent. And then over time, you know, there'll be more people that look different and that look like people from minoritized communities. But it starts with those first one or two.
Mm-hmm.
There's so much, Dr. Rochester, everything she pointed out is so real and present in front of me that I think about it every day. We have lots of research that shows that Black physicians get run out of institutions and even training programs at a much higher rate than their counterparts. And when you ask what the problem is, it's things like they're not professional. What does that mean? The only thing I ever heard was somebody didn't like the way my hair looked, or somebody thought I didn't smile all the time, you know, and you're thinking, is that a thing? How do I navigate this space, right? And so in the last couple of years, there have been some pretty publicly, you know, widespread articles that have shown exactly how often this happens, because people don't believe you when you're talking about it. And so so one of the things we did in our institution was to try to diversify this pipeline, because you asked the question, why don't you have any physicians of color? We couldn't find any. I'm like, well, you know, there are medical schools that are run by historically Black colleges and universities. It has the name Black in the name. You can just go there and see what you find, right? Because if you're looking in this pool, clearly there's none in this fish, in this pool. So go to the places, go to the University of South Florida that graduates the highest number of Latino physicians. Go to University of Oklahoma that graduates the highest number of Indigenous physicians. Go to the places that specialize in, you know, really serving those communities. So just like where you are, and you're trying to serve communities of color, you work with community-based organizations. There are medical schools that have, as part of their mission, really supporting those diverse communities. So go find them. And we set up a partnership with Meharry Medical College in Tennessee, which is a historically Black college. And so we started to bring medical students to do rotations at our facilities. But before the first one ever showed up, we had to train our faculty. We're like, you are not going to make these children crazy. So when they get here, we need you to understand that we are bringing them for their diversity. So we cannot bring them into a system that crushes their uniqueness. And so we had to prepare the ground to receive them. We had the Urban League come alongside us as partners to provide mentorship and support, because, and we refused to bring one at a time. We had to bring them in twos so that they had support, right? So you're not going to drop one person into a place where there's no one who looks like them, no support, and the system is not prepared for them, because we then would amplify the harm. So really being intentional, intention is the key about how you advocate and build those systems. Really important, because to the point made by in the question, having a physician that looks like you absolutely improves your health outcomes, but it's going to take a while before we get that pairing. So to the extent that we can diversify the pools, then others start to learn, you know, from people. They know me and they're like, oh, well, I like her, so, you know, maybe they're not all drug seekers, maybe they're not all the things that I thought they were, because now I know somebody who is a friend, right, in a safe relationship. So
yeah, nice. This is from an anonymous attendee. I'm interested in your thoughts on how genetic screening for diseases and conditions can help or not, when we know that diseases and conditions that predominantly impact BIPOC are less studied. How would you answer that question? Anyone want to take that?
I guess my brief comment on that would be, I agree, like it is true that there is much less research, there are less resources dedicated to the study of diseases and conditions that primarily impact Black, Indigenous, and people of color. That is absolutely true. However, I still feel that there is a great need for genetic testing. You know, we have that capability, and there are lots of genetic conditions that impact even large and small numbers of people, if we think about like rare diseases. So, I think it's yes, and like, I don't think that we should limit the research of genetic conditions or limit genetic testing just because of the fact that currently there are insufficient research dollars being placed on conditions that primarily impact people of color. So I think that there's work to be done in both, I guess, is my short answer.
And thank you to that attendee who's also adding an article to the conversation, a couple articles to the conversation. I don't know if people can see that in the Q&A or not.
So this, Dr. Rochester, all in the context that we are 99% the same, and race is a social construct, not a biological construct. And so while, I guess, complementing what you said with the recognizing that so much bias has been built into the healthcare system, into our algorithms, and so forth, that's such a key area to address and such an opportunity for healthcare advocates, right? If we're advocating for somebody, and we know, we've done our research and we know that it's a place where bias shows up, whether it's in kidney algorithms, cardiac care admission rates for people of color, then we have an opportunity to interrupt bias in those places.
Thank you for that. And I can't believe we're almost at the end of our time. We have just 6 minutes left. It's like, I feel like we've been talking for like 3 minutes. It's gone by so fast. But can we get from each of you what you think is the best, most effective change or strategy that you have seen in the healthcare system regarding race, racism, or bias, something very specific that you've either seen or that you would recommend patients and families do when navigating the healthcare system in the face of bias and race? It's a compound question, but I want to make sure that we get some of this in before we end.
It's akin to, do you have a formula for world peace in one sentence?
Yeah. That's all. No, if anybody can do it, you all can.
Yeah.
I'm hanging on your every word, Dr. Anyaoku.
Well, lean hard. I would say that the big challenge about stereotypes is that stereotypes strip away the humanity of the person in front of you. So whether you're a patient, a family member, a physician, a provider, or an advocate, get to know that person and their unique, their story, their everything that they are, right? They're not one size fits all. And so, it's challenging for a health system that has been taught to advance quality care by uniformity. But uniformity is not, it's not the enemy of getting to know the person next to you. So we think of every encounter as a sacred encounter and think about that person as a unique, special person. Then you get past a lot of things, right? You get past stories that you've heard about people like them, right? Because now you're dealing with me, not with every other version of a story you've heard about me. And so that's the recipe that I would give to everyone. Focus on the humanity, honor the humanity of the person with you, because that's how you're going to make a difference.
Thank you. Dr. Rochester?
I love everything that you just said, Dr. Anyaoku. I talk about the empathy gap and the invisibility in healthcare. And so I agree 100%. We really need to restore just basic humanity and restore the very foundation of these relationships and the commitment to do no harm. And so I think there's a huge role for healthcare professionals and for healthcare advocates to really be aware. And I think this is definitely a start. I think it starts with awareness because there's a lot of medical gaslighting. There's a lot of diminishment of, oh, that didn't happen, or, oh, stop being so sensitive. And so I think that we have to just admit that this is the case. And then specifically to healthcare advocates, I think with that awareness, really understanding that you in some cases may be the one or only person that can stand in the gap for that patient. And particularly if you are working, if you're not a person of color and you have a client who is a person of color, understanding that your very presence in that exam room or at that bedside may be the thing that helps that biased provider, kind of see that patient differently. And I hate that that is true, but it is. So I think it just understanding that in some ways your role may be even elevated even further than we already go to such great lengths to advocate for our clients, but just understanding all of the barriers and challenges that a patient of color is facing, and really being willing to go to bat for them with the knowledge of the barriers that they face, and really being prepared to help dismantle some of those barriers.
Thank you. Annie?
I would say to be curious, to get curious about understanding our own bias. And then own bias, meaning what's inside and how that might prevent us from seeing other people and other experiences. And then I would say read and learn about how racism shows up in healthcare and healthcare advocacy and insurance. And I would say as a third point, research the standard of care. And if you're not sure what's happening and you're in there advocating for a patient, or you are the patient, ask what the standard of care is.
Excellent. That's fantastic. And
Wrap it all up, blossom of humility.
I just want to thank you all, Dr. Anyaoku, Dr. Rochester, Annie Gardiner. Thank you so much for this fantastic post-movie panel. Feel like we didn't have enough time, but we got a lot of good stuff in there. And I would just want to let the audience know that you will be receiving a follow-up email, and in it will be a list of resources, also a survey. If you paid for CEs, you will need to take the survey in order to get your certificate. So please watch out for that. And if you did not get CEs, there will be a survey, and we'd like to hear your feedback on this particular event. And for those who want to share it with other people, we will have the movie available with this post-panel discussion through April the 3rd. So there's still a chance for people to look at it on demand. And if you could share it, that would be fantastic. And in the meantime, also a shout out and thank you to Beth Droppert, who is vice chair at Health Advocate X, who found this movie and brought it to our organization. And we're very, very pleased to be able to host this discussion today. So thank you so much. Thank you, panelists, and have a nice evening. Take care.
Good night.
Good night.